Good. We're welcome back. We're back from the break. So you're thinking about, and we're thinking about the possibility of doing a sleep lab, right?
Yes.
And that should hopefully come to fruition, hopefully in the next couple of months.
That's what we're looking at.
You're meeting with respiratory therapy and a place down, so we're hoping that we can offer that service going forward.
We're also looking at interviewing some acupuncturists to see if we can't get a acupuncturist to come out here.
Yeah, help with,
and treat. It's another avenue to treat pain that's very, very effective.
Oh, I think for radiculopathy, it's very good. So that's a good thing. And you've got some exercise equipment coming, right?
Yeah, we got some rehab equipment that's purely isokinetic, which is a great big word, but there's no residual muscle soreness the following day after you train on this equipment because it's just a contraction load. Excellent for the older geriatric population because it's very kind to the joints.
Mm-hmm. That's something you invented, right?
Yeah, I invented the software that went with this. I didn't invent isokinetics. I wished I would have.
Well, I mean, but you had some part in that. So
yeah,
I mean,
I helped develop the equipment and created the software that goes with it. Yeah,
that's good. That's cool. So
Chuck.
Hey guys, how you doing?
Hey Chuck.
Hey, I got a friend who's in his early 70s and in real good health, very thin, not overweight, etc. Anyway, a couple of years ago, he suddenly started getting real dizzy and threw up and all the rest. And it hit him out of the blue, and then he increased his water intake, and it seemed to subside, but now it came back. And he goes through the VA, and they said he probably got, vertigo. But I was wondering if you could talk about it, and if he was going to come to you, what kind of tests would you run, if any? And is there anything he can do maybe to offset the vertigo, if it is in fact vertigo?
Well, vertigo is just a term used for dizziness, but I mean, it's really what is the cause? I mean, and this is the part that's a $64 million question, or that's just a $64,000 question back in if you were talking in the old days, but. Basically, we have two balance systems in the right and left, and they're in the middle part of the ear. So they are bent to basically, if you turn your head one way or the other way, the fluid in there will shift the opposite way. Mm-hmm. And so it's always based on getting the right input. And if the brain doesn't have eyes to the outside world, even though it has eyes, but it really, on this side of the coin, they don't know what's going on. So if you turn your head a certain way and the fluid in the brain gets alternating input, it doesn't know what to interpret, so you will spin. And that's positional vertigo. So if you change your position quickly, you tilt your head back, or you do something that's called positional vertigo. Very common disorder. There's also a little bit of what they call orthostatic. Mm-hmm. So if you stand up quickly and you're on a blood pressure pill or you're doing something like that, your venous tone doesn't correct and blood will drop down and you will do that. So I don't know what testing your friend has had. Increasing the fluid probably increased maybe blood flow. And volume, and that might have helped him initially. But if he had some vascular constriction or he had something process going on, it may have overcome what he did to change that.
Well, he said there was a component of nausea, and if he was throwing up, then there could be an electrolyte imbalance, there could be any number of things, and the water would address that.
The water would address it, but whatever it was that he corrected, to me it sounds like a vascular process, because whatever he increased his volume, he might got some increased blood flow, but the vasoconstriction that was started back then has overcome the increase in volume. So an MRA, which is a magnetic resonance angiogram looking at blood flow in that area. There are cerebellar pontine angle tumors, very, very rare, but you can only pick them up with an MRI. You cannot pick them up with a CAT scan. So you always, when anybody has chronic vertigo, you always want to do a MRI looking for an MRA looking for CPAs, or cerebellopontine angle tumors. They're a very tight area in the brain, but it is one of those things you don't want to miss. So I think at least he needs to have his heart looked at to make sure that he's got a good echo. He needs to make sure his vascular in his carotid system is good, and he needs an MRI, MRA, and probably maybe even a neurologic exam. But you know, at the VA, I don't know exactly all they do, but that's how I might start that workup. They also do some tilt testing. There's also some other things that they do, and having chronic vertigo with no cause is really debilitating.
Oh, yeah.
But you know what's really good for it is Valium, 2 milligrams twice a day. I used to get laughed at by some of the EMT people when I put people on 2 milligrams of Valium, but because they think Valium is a tranquilizer. But really, when it comes to this vertiginous input, it really slows down that input, so it helps balance it. So there's been a couple of my patients that have chronic dizziness, and I put them on that, and they're like new people. So antihistamines sometimes can help. Benadryl, one of those things, might give you an indication that Valium or all those things might work. So hope that answers your question.
Yeah, great, thanks. I got one more. Yeah, I've been on this vaccine kick lately, among other things, but I read something today that I found interesting, and it basically was from an input into the British Medical Journal back in 2013, and this PhD did a study on influenza, and he found that, and I'll quote it, every year hundreds of thousands of respiratory specimens are tested across the U.S. Of those tested, on average, only 16% are found to be influenza. So in other words, what he's saying is so many of the people that are told they've got the flu end up, after the testing, to not have, you know, the viral influenza. And I just thought that was an interesting finding.
Yeah, and I would think it would be more rhinoviruses and colds and bronchitis, but there was, you know, one thing that's been going around for about several years in Pahrump has been what I believe is a resurgence of diphtheria. Because they've had these coughs that have lasted for 2 to 3 weeks following a really bad upper respiratory infection. And I think what's happened is that people that were immunized in their younger years for diphtheria and pertussis, and it may even, you know, it's not a pertussis, but that immunity has waxed and waned over the course of a time. So now you're getting it again, and you know, and what you go to get a tetanus, you get a tetanus booster. You're not getting a DPT booster. So that's one of the things that may be out there, and. You know, these rhinoviruses, they mutate. It might be even something that we don't even know. I mean, it could be something crossed between another influenza and a rhinovirus. And so, you know, if they're testing for influenza, but it's some variant thereof, then we would never even know. And the one thing that I find very interesting about viral analogy now with the DNA, PCR and all the things, they can actually look at a virus and tell where genetic material, where the host was, how much is bat, how much is pig, how much is bird, and all these other things. And they can actually follow its transmission from where it came from all the way to where it is now. It's just amazing what they can do. So I don't know if anybody's doing that, Chuck. If they're analyzing those viruses, they're just looking for influenza, but they're not looking for anything else. So.
Yeah, okay. Well, thanks a lot, Doc. I'll get off so other people can call.
No, we listen. I mean, we appreciate the calls. It helps me from just repeating myself over and over and over.
And you always have good input, Chuck.
Oh, thank you. Well, one quick one before I go. I talked to a friend of mine that lives in Wisconsin yesterday, and this Lyme disease is so underreported, the magnitude of it, and the incredible problems people are confronted with their whole life. And again, I've looked into it all day today, the whole scientific background of it, and it's a nightmare because it's almost impossible to diagnose, and certainly they found it impossible to treat. And of course, the question of how long people should be on antibiotics, et cetera, has turned into a firestorm. But my friend said as many as 80% of the people in Wisconsin are believed to have Lyme disease. And it's incredible. It's just destroyed his daughter, who got it when she was about 20. And she's been in wheelchairs, and it's just a horrible disease that is so little reported. So anyway, I'll get off now. Thanks a lot, guys.
Good night, Chuck.
Yeah, and you know, Lyme diseases are rickettsial type bacteria transmitted by the deer tick. But anyway, it sounds like to me there could be something more than just that with that particular patient.
Yeah, but I understand it can lay dormant in your system until you're compromised, and then you experience this.
There's an antibody test for it. I mean, your body has to build an immune response to it, but if your body doesn't build an immune response, you can't test for it. And tetracycline really kills it. But I mean, you know, how long do you want to take that product and deal with it? But I think it's like the advertising for hepatitis C. You know, it's kind of like if you're up there, get tested, get treated. As these diseases start making an impact, they start testing is done. I mean, more resources are thrown at it. So just like Zika, right?
Yep.
All right, we're going to go to break. We'll be right back.